Hi, this is Mel. I'm going to provide some insight on the patient that I have for this project. So, the patient that I have is a 36-year-old female. The chief complaint is of low back pain due to movement performed during gymnastics in high school. So, with her, in her back was incapacitated for 7 days, or she was incapacitated for the past 7 days with this low back pain issue. In addition, the radiographs identified a grade 1 level spondylolisthesis for this patient, and then the aggravating factors are going into hyperextension during a routine with multiple back springs and gymnastics. So, from the neutral position, she can only extend 2 centimeters before she gets into immediate sharp pain of the low back. The easing factors, so which typically the symptoms improve with the long axis leg traction motion, and the pain score is 2 out of 10 immediately with the long axis leg traction position. The severity, she presents with the 5 out of 10 pain. The severity is noted as standing in extension during a movement screen, and then these symptoms were responded to during that motion for the 5 out of 10, with her describing that motion as consistent throughout the day. The irritability, or that is her pain pattern. Irritability is 1 to 1, which is noted because in the 5 second time frame, we're just putting it 1 to 1. It doesn't take an additional minute plus. It's in the 5 seconds to return back to normal. The past medical history demonstrated some elements of on-off bladder issues. So bladder infections and the urinary tract infections are persistent for the previous 3 months. So not necessarily a red flag, but a yellow flag is what I wrote down for this one, because there were no red flags. The yellow flags were just some of the excessive or drinking past the 10 per week, 10 drinks past the 2 to 3 drinks within a week. So current medications, she's not taking any current medications, but she is taking Advil on a regular basis, just an over-counter medication just to subside the pain. Physical examination, we noted that the neuromotor sensory screen demonstrated poor recruitment of the multifidi bilaterally at L4, L5, and L5S1, in addition to the transverse abdominis muscle weakness. The paraspinal bulk was bilateral from L1 all the way to S1. The muscle stretch reflexes and patella and Achilles tendon reflexes were normal. The neurodynamic tests, such as the slump test and the SLR, the single leg raise, were all negative. Symptoms were provoked with an axial compression, which resulted in lumbar extension and elevated pain. Pain levels from a 5 to a 10. In addition, passive accessory intervertebral motion tests at L5 reproduced the complaint. So it reproduced the issue that was there. And the key impairments were standing for over 45 minutes and an hyperextension of the low back. So the diagnosis is consistent with grade 1 spondylolisthesis, as well as the physical exam is consistent for identifying L4, L5, L5, and S1 motor testing, which was secondary to the grade 1 spondylolisthesis diagnosis in the image report. So the plan going forward is the approach is for us is to self-care management, utilizing the appropriate rehabilitation approach for sensory motor stabilization exercises with some additional strength and conditioning exercises at heavier loads to improve the underlying strength deficits and the pelvic floor inconsistencies or the pelvic floor instability issues that's present here. Any questions following that? Oh, okay. All right. Thank you so much, you guys.